Welcome everyone to our webinar on innovations in fibromyalgia treatment, what's new in research and clinical care. I'm Nicole from Swing Care, and I'm excited to welcome our guests, Dr. Andrea Chadwick, Dr. Anna Woodbury, and Dr. Mike Rosenbluth for a wide-ranging conversation on the state of fibromyalgia care in 2024 and what patients can expect to see in the year ahead. So just to give a little bit of background on our guest before I jump in, Dr. Andrea Chadwick is Medical Director of Swing Care and double board certified in anesthesiology and pain medicine. Her clinical expertise focuses on complex centralized pain syndromes, including fibromyalgia. She is also director of the Fibromyalgia and Centralized Pain Exploration Lab at the University of Kansas Medical Center. Dr. Anna Woodbury is Associate Vice Chair of Research for the Department of Anesthesiology at Emory University and double board certified in anesthesiology and pain medicine and licensed in acupuncture. She founded the Division for Pain Management at the Veterans Affairs Healthcare System in Atlanta in 2014 and is active in research at both Emory and the VA. Her goal is to understand the neural bases of chronic pain in order to innovate and evaluate novel therapies that maximize benefit while reducing risk, improving quality of life and function for her patients. And Dr. Mike Rosenbluth founded Swing Therapeutics in 2019. He has been dedicated throughout his career to translating innovation in healthcare with focus on delivering better care for underserved diseases. He and his colleagues led the development of Stanza, an FDA-approved digital behavioral therapy for treatment of fibromyalgia symptoms, backed by the largest clinical trials ever conducted for a fibromyalgia device. He holds a PhD in biomedical engineering from the University of California, Berkeley and University of California, San Francisco. So lots of credentials with us today. Thank you so much for being here. And Dr. Woodbury, I'd like to start with you and your research. I know you focus on the neural basis of chronic pain. Can you share more about what that means, particularly in the context of fibromyalgia?
Sure. Yeah. So I think there is a lot of neuroimaging research that has already been done in fibromyalgia. And what our group is doing is helping to further develop that as a tool for evaluating fibromyalgia and other chronic pain states. I think one term I heard recently is that the pain is not in your head, but it is in your brain. And so we look at some of the resting state functional connectivity, MRI, which is basically the way different areas of your brain talk to each other in chronic pain. And specifically in fibromyalgia, what's been shown is that there are certain areas of the brain that are talking to each other that really shouldn't be talking to each other. And when you give them therapies that help reduce the pain, you will similarly see a decrease in some of that crosstalk. And it's not necessarily always a decrease. So there are areas of the brain that should be talking to each other, and there are areas of the brain that shouldn't be talking to each other. And so sometimes you'll see an increase in communication between areas of the brain that are supposed to be interacting. So we can see that with resting state functional connectivity MRI. There are other ways to use MRI and other neuroimaging tools like PET to evaluate what's going on in the brain. So one of the things we're also exploring is something called magnetic resonance spectroscopy, where we look at measures of neuroinflammation and also GABA and things like that, where you can look at the neurochemicals in different areas of the brain and see if they are either upregulated or downregulated, depending on the pain state. There's a lot of other tools we're evaluating also. So we also look at white matter tracks and basically axonal projections. You can kind of look at axons using it's called DTI, which is another method of acquiring scans in the MRI. And so we can look at the tracks, and that's another part of it. We also look at gray matter structural changes. So some studies in fibromyalgia show that there are what we call regional gray matter abnormalities, which means that the total brain volume is the same, but parts of the brain have more gray matter than they should, and other parts of the brain have less than they should in a healthy state. So we're taking what's been found in the literature, and then we're doing pre-post scans so we can see if our devices and our interventions are changing the brain as we improve clinical outcomes.
Wow, got it. And so, I know that looking at MRIs is something that we've talked about before in terms of understanding kind of the neural basis for fibromyalgia, but it sounds like there are also like structurally some things that you're looking at as well in terms of, the gray matter. Can you say a little
Yeah.
bit more about that?
Sure. Yeah, there are structural changes. And what was really interesting for us was that we actually saw changes in the structure with our treatment over just a 6-week period, which I think is wild because I didn't know that the brain was that neuroplastic, right? So in terms of the areas involved, we looked at certain areas of the default mode network and the anterior cingulate cortex. And what's interesting with our study, at least, was that we expected things to kind of go back to what you would see with like a healthy normal state, like with healthy controls. And we didn't really see that. We saw just changes, not necessarily towards a healthy state, just different changes, which we think kind of is a sign that there is some sort of neuroplastic or a response happening that may eventually, plateau over time and come to a different, like a healthy, normal state.
Got it. So backing up a little bit to talk about the treatment that you were mentioning, since this is about, research and treatment, I would love to hear a little bit about, the treatment that you were researching that led to some of those changes.
Sure. So with that particular study, what we used was a type of therapy called percutaneous electrical nerve field stimulation, which is a long way of saying that we insert needles, percutaneous, into areas near nerves. We did it at the ear. And we were targeting auricular branches of the cranial nerves, including the auricular branch of the vagus nerve, which we think is really what's mediating most of these effects. And then field stimulation. So because there's multiple electrode arrays that are arranged around the ear, it stimulates like the entire ear. And that's why I can't say specifically that is transauricular vagus nerve stimulation, because it's not just targeting the vagus nerve. So there are branches of the occipital nerve here and also the greater auricular nerve. So we're stimulating several of the branches of cranial nerves here. But we saw a positive effect. And what was really interesting for us is because we followed these individuals over a 12-week period after they'd already stopped having the device. So we did weekly treatments, and it's an acupuncture-like device is what I would describe it as, kind of like ear acupuncture, but there's a little battery pack that goes on the back of the ear, and then it stimulates these electrode arrays continuously over the period of time that the device is placed, which is 5 days. And so we would have them come back every week to remove the device and replace it with a new one over a 4-week period. And we looked at changes at that immediate post treatment period. And then we also looked at it further out. So this was an open label study. That means that patients weren't blinded. They knew if they were getting the device or not. So that's, one of the key things about it. But so there may have been a placebo response, but what we saw was both our standard therapy group, who came for weekly visits and had medication adjustments. They even got acupuncture sometimes. They went to a pain psychologist. So it was very, I didn't want to change the way that clinicians and their patients interacted too much. So it was very pragmatic in that fashion. But then the treatment group got the device placed weekly. So with both groups, they decreased in their pain levels immediately following the 4-week period. However, the standard therapy group kind of gradually went up to baseline by 12 weeks, and the treatment group stayed. So again, we think that like we basically created a neuroplastic response that resulted in a longer term decrease in pain and improvement in physical function. So we felt the purpose of treating pain is to improve function and quality of life. So we measured those things as well. And the participants were able to do more sit to stand tests. So more, getting up out of a chair multiple times, more bicep curls. And also we tested hand grip strength.
I know you mentioned, yeah, like vagus nerve stimulation generally, and also acupuncture. We've talked about some of those things in past webinars as, general treatments for fibromyalgia. Um, how do you see this device kind of being different to, going to acupuncture or doing kind of, breathing exercise to stimulate the vagus nerve, something like that?
I think one of the things about it is that it delivers this continuous stimulation on a duty cycle over a 5-day period. So it's almost, if we were to talk about the device in terms of like a drug dosing, then you're getting more of a dose, and you're getting it over a longer period of time. So one of the problems, I do acupuncture, so I love it. But one of the issues is that you have to go for multiple visits, and it does have a cumulative effect, but it can be a burden to drive out there and get acupuncture, to schedule an appointment if your provider doesn't have any availability. And what I've seen with a lot of my patients is they can have long-term relief. Some of them do, but a lot of them have just 2 days or even just a few hours of pain relief. So with a continuous stimulation device that is giving you this treatment over collectively, a 4-week period, then you can kind of get a higher dose and a higher input to potentially create that long-term neuromodulatory effect.
I'm sure our viewers are going to ask, where can I get this? How can I try it? How are you seeing this translate into clinical care for fibromyalgia in other ways yet, or how is that looking?
So what's great about this device is that it's already FDA approved for a few other indications, not yet for fibromyalgia, but what that means is that physicians can use it off label, since it is FDA approved for irritable bowel syndrome, or specifically actually functional abdominal pain in adolescents. So that device is called the ID Stim. And then it's also FDA approved, but through a different company, Massimo, for opioid withdrawal. So it was originally, I think it was one of the breakthrough devices for opioid withdrawal symptoms when people were acutely withdrawing. So because of that, it's readily available on the market. I think that eventually they will pursue, one of the companies will pursue an FDA indication for fibromyalgia or chronic pain. What I'm hearing is that they need a very specific indication to go for. And then with enough research and evidence, then they can get it approved for that, which means that hopefully eventually insurance companies would reimburse for it. And I think that would be the key. So I work in the VA system, and I can access these devices pretty easily as long as they have a federal contract. And that's nice. But I would like to see more widespread availability.
And Dr. Chadwick, are you seeing either with this device or with some of the same mechanisms, how that's translating into your practice with your patients?
Here at the University of Kansas, we don't have that available, but boy, do I wish I did. That would be really wonderful to be able to offer patients. And it's really amazing to see that there's kind of these longer term neuroplastic changes, as Dr. Woodbury was talking about. So even after the device is done being used, you're seeing this carryover effect. And I think that's really hearkening to the way that it's actually working to kind of reverse some of those maladaptive, neurobiological processes that are kind of fueling that fire of fibromyalgia, that increase in, pain sensitivity and pain to non-painful stimuli. So I think the work that she's doing is really fantastic. And I hope that it does kind of bleed over to more mainstream clinical care here in the near future, because I mean, I can speak for my patients. I'm sure Dr. Woodbury can speak for hers, but patients are constantly looking for treatments that have lower amounts of side effects, are more kind of natural in a way. This is, basically kind of like acupuncture on steroids, I would say. But I think patients really like the idea of something where they're, not having side effects and not having to, worry about the medication making them feel groggy or not function to the way they'd like. So the fact that Dr. Woodbury's team is even measuring those physical functioning outcomes like the sit up and stand test, those types of things, is just fantastic. So good job, Dr. Woodbury. It's really
Thanks.
great work.
Yeah, and if you want to get it at your institution, I would actually suggest kind of going to the pediatric GI people first, because they have an FDA indication for functional abdominal pain in adolescents, and the peds GI people see a lot of that. So they would, if they don't know about it yet, then I'm sure they would be excited to hear about it, and then they can get it into the institution, and maybe it can trickle out from there.
That's great advice. Thanks so much.
No problem.
And since we're on the topic of non-drug approaches to fibromyalgia care, Dr. Chadwick, like you were mentioning, Dr. Rosenbluth, you were an author on the recent publication in The Lancet on a clinical trial for fibromyalgia devices as well. I was wondering if you could share a little bit more about that and what the treatment was and what you found.
Yeah, absolutely. So I think at the founding of Swing back in 2019, what we were struck by is that if you look at the guidelines for best practices for fibromyalgia care, it really is multimodal. It's an all of the above approach, which includes some of the drugs, but also includes non-drug options, including cognitive behavioral therapy. I think what we were struck by was just the large amount of evidence and study after study that showed the benefits of helping people manage their fibromyalgia symptoms. However, most people just didn't have access to it. When we talked to different prescribing physicians who manage fibromyalgia, they're like, yeah, we know this works great. I don't have someone that I can refer this patient to. There's no one out there. That's just like not part of my care. I generally just tell people, here's some drugs that might work. Here is, some exercise regimens that you might be able to do, and we'll see you again in 3 months and see how that goes. And so what we thought of was, how could we make this more scalable? How could we make this more broadly available? And so we found some research going on in Canada at the University of Manitoba that looked at a type of cognitive behavioral therapy called ACT, or acceptance commitment therapy, and was delivering it online in an internet delivered fashion. And they were showing some really great results in helping people better manage their fibromyalgia. And so that gave us the nugget to build a smartphone app, which is called Stanza, to deliver ACT digitally for patients. And so we built the device, built the software application, and then run about 6 clinical studies on the actual device, and it was cleared by the FDA earlier this year. So just at a high level, sort of the overall concept of ACT, or acceptance and commitment therapy, is a term that a psychologist would call psychological flexibility. And that's really like, how can you help someone change their relationship with their symptoms, change their relationship with their pain? And instead of saying what you should focus on is like trying to make your symptoms go away, it's more trying to direct you to what are those values? What are important aspects of your life that maybe your disease and your condition has stopped you from being able to do? And how can you do things more consistent with those really important values in your life? And as best as possible, really trying to make those symptoms of fibromyalgia not the central part of your life, but something on the side, something that you can live your best life alongside those symptoms and alongside your pain. And when you start to do that, the evidence shows that those symptoms can actually go down. And so what we recently showed with our co-authors is that that in fact happens. And so looking at all the primary, secondary, and exploratory endpoints, around pain intensity, fatigue, pain interference, depression, physical function, overall fibromyalgia severity, that we showed significant benefit of Stanza against what we developed was an active control arm, in a sense of giving someone a different intervention that we thought was not going to be necessarily active, but could take into account a lot of the different biases that can happen in a clinical study. And so we showed significant benefit of Stanza against that active control. As you said, it was the largest device study that's ever been run in fibromyalgia. It was the basis for the clearance by the FDA last year. It was run in 25 sites, and I think really moved the field forward in a sense that typically a lot of these studies before on ACT were sort of in a single institution. They were a pilot study, and at the end, the conclusion was always more research should be done over a broader population. And so we're like, well, let's do that. Let's do that more research to actually really definitively validate the benefit, and really proud of the results that showed that.
Thank you. And I know you mentioned using Stanza in the context of comprehensive care. And I think Dr. Woodbury, you mentioned too in your study, patients were not just doing this, they were also doing other things and kind of keeping their standard of care that they were working on previously. I know Swing Care recently published results from our clinic, which focuses on comprehensive fibromyalgia care. And Dr. Chadwick, I'm wondering if you can share a little bit about that and kind of why comprehensive or like multimodal care is so successful.
Absolutely. And, it's the work that's done by all of our investigators on this panel today is just really astounding. And I think what this all kind of highlights is that patients with complex centralized pain, fibromyalgia, and other types of chronic overlapping pain conditions really do need an integrated approach to be able to tackle the symptoms they have, which include other things than pain. Some of the endpoints that Dr. Rosenbluth was just talking about were, on fatigue and sleep issues, and it all is part of their overall picture. And some patients may have more pain than others. Some patients may struggle with fatigue more than others. And so really having that integrated patient-focused approach is really kind of the concept that I know all of us that are clinicians on this panel abide by. But there's definitely a paucity of clinicians across the country, such as myself and Dr. Woodbury, who see and manage fibromyalgia in the long term. And so one of the things that I've been very proud to partner with Swing Care on is creating that space for interdisciplinary care for patients, just like Dr. Rosenbluth was talking about scaling ACT, the whole focus at Swing Care is to scale chronic fibromyalgia care for patients in this country who can't access a fibromyalgia provider where they live, because there are very few of us. I'm sure Dr. Woodbury would agree that, people who take care of and treat fibromyalgia chronically, we're like little unicorns scattered across the country. It's an honor to be a fibromyalgia doctor, and it was an even bigger honor to help partner with Swing Care to scale that towards, a more national presence. So one of the big data points we have from Swing Care just in the, a little bit over a year that we've been in practice is that, our patients get this nice comprehensive care, but we have the data to back it up. So we show, improvements in the patient global impression of change that is strongly, significantly improved. We see decreases in fibromyalgia severity symptoms. And that's really what any good clinician wanting to take care of fibromyalgia wants to do, is reduce symptom burden and improve functioning. That's the goal. So just so proud of the clinicians that see our patients here at Swing Care. And it's been, a big honor of my career to help, create that clinic in the mold of interdisciplinary care.
Yeah, thank you. And I also wanted to touch on kind of a theme that I'm hearing from everyone here, which is just using these technologies to increase access to some of these treatments. Dr. Woodbury, I think you mentioned, being able to have this device so you're not going to an acupuncture appointment every week, or Mike mentioning that, ACT is, or cognitive behavioral therapy is a guideline-directed treatment, but I think 5% of people with fibromyalgia actually get access to that. And sort of in the same vein, having this virtual visit with comprehensive care available to people that don't have to go see, Dr. Woodbury or Dr. Chadwick in person I think these new technologies can be so helpful, and it's nice to have the research also indicate that they're very effective as well. So I wanted to, Dr. Chadwick, we haven't kind of turned our eye to you yet. I know besides being medical director at Swing Care, you run the Fibromyalgia and Centralized Pain Exploration Lab at the University of Kansas. So I'd love to hear about some of the studies that you're currently running out of your lab.
Well, I have quite a few, and all of them are like fibromyalgia-esque, which is the theme of what I do. I mean, most chronic pain syndromes have some form of nociplastic pain as their kind of driving pathophysiology. So we just are finishing a study in chronic low back pain that was done at 13 other sites across the country through the National Institutes of Health, called the BEST study. Of which one of the therapies is ACT. So there's that as well. And we do know from some research that I've done in the past and others across the country have shown that, a subgroup of chronic low back patients do meet criteria for fibromyalgia and also have been shown to have, quantitative sensory testing features consistent with what we call central sensitization. So that study is just wrapping up, which is really exciting. We were able to recruit about 70 patients at my site, but nationwide, about 1,000 people were recruited total for the study. And it was a very cool design, very pragmatic, where patients kind of got randomized into one of 4 arms at the beginning. And then depending on how they were doing, based on the PGIC, they would then either stay with their current treatment if they were doing well. They could stay with their current treatment, but get that augmented with another treatment therapy, or they could get completely re-randomized. So it was meant to kind of mimic what clinicians do in practice, where if a patient's somewhat better, you might add another therapy to get an additional benefit. So it was a very, very cool study, and I hope that the results are going to be helping clinicians across the country better tailor their treatments for chronic low back pain. Other than that, I have a couple other studies from the NIH that are just getting up and running. One is looking at mechanisms of pain relief from peripheral nerve stimulators. And I'll be working with Dr. Jennifer Ha at Stanford and Dr. Sandeep Biswal at the University of Wisconsin-Madison to do those investigations. We have not yet started recruiting. And then another study, just kind of going back to fibromyalgia, we have a study where we're asking patients how they use music to treat their chronic pain related to fibromyalgia. And this was a little spin-off of a study where we actually did do a music intervention in fibromyalgia patients. Unfortunately, it happened right before COVID hit, and so we were stopped early on those results, but we did publish a study of that small sample size of pilot patients that showed that their autonomic nervous system features were essentially improved to be more parasympathetic after they had listened to music. And that kind of goes back to the vagal nerve stimulation that Dr. Woodbury was talking about. We know patients with fibromyalgia can tend to live in a bit of a fight or flight mode, which is that sympathetic activation, and that part of kind of improving their pain processing, et cetera, is getting them into that rest and digest parasympathetic mode. So we believe that the music listening actually provides a true analgesic effect. We only have short-term data, but we are planning to use the study results we get from this survey, as well as our previous work, to put in a larger grant application to look more deeply at the analgesic effects of music listening.
I love to give our patients an idea of, what is on the horizon. So any other studies that are kind of on your radar? It doesn't have to be from your labs, but curious about what you're seeing.
Okay, so the cranial electrotherapy stimulation is one of the types of non-pharmacological approaches that we're also using. And this type of stimulation uses what we call transcutaneous alternating current stimulation. So there are a lot of different non-invasive brain stimulation techniques out there. I'm going to list a few I've sort of toyed / done a little bit of research with all of them. One is repetitive transcranial magnetic stimulation. So that involves a big magnet where you deliver an electromagnetic impulse to deep cortical structures. It's been used, it's FDA approved for depression, for OCD or obsessive compulsive disorder, for smoking cessation. But a lot of research is being done to evaluate this therapy for pain as well. So that should be on everybody's radar. There is a peripheral magnetic stimulation device that is currently FDA approved for peripheral nerve pain called Neuralace. So that one is already out there, but some of the traditional RTMS machines are MagStim, MagVenture, and they're looking at the central nervous system stimulation to treat pain. So that part is really interesting. And then there's also TDCS, or transcranial direct current stimulation. So unlike RTMS, you can't get as deep with this electromagnetic impulse. You just do, it's more like a TENS unit for your brain. But you can target sort of the superficial cortical areas. The thing with RTMS is that there is this potential to induce a seizure if you do it wrong. Okay, so people have to be trained in it and they have to do it right. With TDCS, that doesn't really happen because you're not targeting the same areas. Both of those therapies use direct current, so they're more like turning neurons on and off. TACS, which is the cranial electrotherapy stimulation, it entrains the neurons. So it's getting the neurons to fire at the same pattern as the stimulation. So the device we use is called AlphaStim. It's readily available. You can prescribe it, so it has to be prescribed, but it is available by prescription. And that one is FDA cleared for, it's very, very safe. So FDA cleared for insomnia, for anxiety, for depression, and for pain. So it's really nice because it's just these ear clips and patients can use it at home anytime. They just turn it on. And so we did a study with that during the pandemic. And what was really nice was that we didn't have to have people come in for multiple visits. We could just show them how to use the device and then they go home. And then we asked them to use it daily. And we saw a reduction. I can't, I don't have everything analyzed yet, but we did see a statistically significant reduction in pain with like a all group analysis. And in general, people feel better. If you try the device, which I did, because again, it's very safe, you feel like a very clear physiologic effect, which is also very interesting to me. Like you feel like you're walking on a boat and then you're supposed to turn it down a little bit. But it's entraining the neurons to fire at an alpha frequency. So it's kind of like an induced meditation or like a light trance state right before you fall asleep. So I think of this as like because I personally have difficulty meditating. And I think a lot of my patients do too. And so I think of this as a way to kind of kick you into the meditative state without having to do as much of the work. I know that sounds terrible, but yeah, so that's another one. So all of these therapies, RTMS, TDCS, CES, and then of course VNS, the vagus nerve stimulation, which can be done at the ear or over the neck. I think all of these therapies have potential to be another option for treating fibromyalgia, if not right this minute, then in the very near future.
So I know that there's been some studies recently, just even within the last few months, there's been press releases on long-acting cyclobenzaprine for the treatment of fibromyalgia. I'm sure we're going to see some additional efficacy trials on cyclobenzaprine. That's been on my radar. I've been kind of keeping tabs on a study where they're using metformin to treat fibromyalgia. I think the study is being done in Utah. So there is some evidence that metformin in animals and an animal model can improve fibromyalgia type symptoms in animals. And they feel that maybe there's some sort of glucose mediated insulin resistance kind of issue that might be driving fibromyalgia symptoms. So that'll be interesting to see what that study shows as well. So those are two that are on my radar.
Dr. Chadwick, I'll ask you a question about that one. I think the benzaprine one is it's a novel type of delivery, right? It's like a sublingual
Sublingual.
solvable. What's the thought behind that, and why that might be, differentially effective?
I mean, my understanding is that it provides a much more rapid delivery and uptake of the drug, and that might help get people to sleep easier. But it'll be interesting because when I saw sublingual and that it was long acting, I was a little confused, but I'm excited to see what it shows because I do use cyclobenzaprine a lot in my patients. It can be helpful for getting restorative sleep. It can also, by its mechanism of action, improve serotonin profiles within the brain. So yeah, it's to be determined.
And I believe that company, I think it's Tonix Pharmaceuticals, is going to be submitting that to the FDA in the coming months. So it was nice to see them investing in some large scale clinical trials for new drugs.
Well, yeah, because we have not had anything new for fibromyalgia in over a decade?
Yeah, that's right. Also, I know that you sometimes use low dose naltrexone in some of your patients. Could you talk a little bit more about that? And I'm just curious about that and how you see that as part of clinical care.
Yeah, I mean, I kind of stumbled upon low-dose naltrexone just in my usual readings and journals and whatnot. And I immediately was kind of scratching my head because, when I was an anesthesiology resident, we would sometimes use naltrexone, but it would be at much higher doses for like itching. And then I'm aware of its FDA on-label indications for opioid use disorder and alcohol use disorder. So I started reading more about it, and this is all from Dr. Jared Younger's work at University of Alabama, Birmingham. But there's a very compelling argument that at low doses, the low dose naltrexone is actually working to kind of offset or inactivate a pathway that creates glial cells being kind of turned on. And so glial cells are these cells that exist in your spinal cord, in your brain, to basically, when they're activated, they create inflammatory cytokines, which are molecules that are very, like I said, pro-inflammatory. And so when you have pro-inflammatory cytokines being released in the central nervous system, it can be a bit of a fuel on an already existing fire of central sensitization. So the low dose naltrexone is felt to kind of shut down that pathway. And so I felt mechanistically it made sense. And looking at the studies that Dr. Younger did, they showed efficacy. So I started using it, I would say probably about 5-6 years ago in my practice. And it's been a really cool journey. I would probably venture to guess I have at least 200 patients on it right now. But it seems to, when it works really, really well for patients, in improving their pain. And it can improve their fatigue in some instances. And it's a really low risk drug because we're essentially kind of micro dosing an already existing drug. So it's still off label because it's not being used for its on label indications. And it's so low dose that we have to use compounding pharmacies to make it in the doses that patients need to take for that. But I think I like it because it's low risk, low side effect profile. And I used to use it much more for like refractory cases, but now I'm kind of using it first line in some indications because most patients tolerate it. They're able to, not have sedation from it. And if it works, it can be very good for them to have a medication that doesn't cause them significant side effects.
And I just want to kind of wrap up today. I just really appreciate all of you being here. I know we're getting close to our time, but I think we tackled a lot today from all of your research and other research that you're curious about, excited about for the future. If there are patients that are interested in like learning more about your research or other research in fibromyalgia, are there any resources that you would recommend people check out?
They should definitely check out the American Fibromyalgia Syndrome Association, which I think they just revamped their website, and they collate several research studies, both ongoing and past, on their website. So that is one resource I would definitely recommend.
And I think I always recommend to patients to go online to clinicaltrials.gov, and you can search for any active or past clinical trial, but looking for active clinical trials. If they're interested in being a participant, you can go there and search for studies that are actively recruiting. And I think just the NIH is always a good resource as well, to look at what the current funding structures are, or what they're currently getting ready to publish.
Great. And we'll post some links in our chat as well for people that are watching this, but really appreciate all of you being here today. Again, I'm Nicole from Swing Care. You can check us out at swing.care or in our private Facebook community, which is called Life with Fibro. We post early links to some of these webinars, as well as get Q&A from our members. So always excited to meet new fibro friends on our community. And again, looking forward to talking to you next time. I hope we get to learn more about some of the results from some of these studies that you're currently working on and analyzing. So thank you so much.
Thanks so much, Nicole.
Thanks
Bye.
for having us.
Thank you for having us.